But thank you all so much for joining. I am going to go ahead and kick us off. Welcome to this month's AOT Learning Network web chat for AOT Monitors. I'm Brooke. I am the AOT Implementation Manager on the TAC team. Um, and just kind of some background, the monitor role might have a different label in your program, but we use it to refer to anyone who's serving as the liaison between the court and the treatment team, doing things like monitoring delivery of services, patient adherence, that kind of stuff. And this discussion will focus on addressing common issues monitors face. So this is an opportunity for you all to share, to ask questions, forge new alliances, stuff like that. And so the more engagement we get from you, the more beneficial the chats will be for everybody. If you were forwarded this notice and you're not part of our AOT Learning Network yet, definitely consider joining for more events like this one. And I'll drop the link to join the network in the chat during our discussion. And then just a heads up, the chat is being recorded and it'll be posted to TAC's YouTube channel and shared with you as a resource over email. And finally, if you haven't already, consider, and if you're able to, consider turning your camera on just so we can build community during the chat. So we are going to start with introducing our team, and then because we have a small group, I'll go around and have you all introduce yourselves based on the order I see you on my screen. And then after that, we have Erica Lopez, special guest who heads the AOT program in Webb County, Laredo, Texas. Kick us off with a little bit or by sharing a little bit about how they utilize telepsychiatry in their program. And so then we'll go from there. So for the introductions, if you could just share your name, your location, and your connection to AOT, that would be great. And I have talked enough. Like I said, I'm Brooke. And Amy, do you want to introduce yourself? You're muted.
I wasn't sure whether the birds were coming through. My name is Amy Lukes, and I have been with TAC for almost 7 years. I'm a social worker by training. Uh, my expertise is in providing clinical services to people with severe mental illness. And in my past, I did work in a system that used assisted outpatient treatment, although we did not call it that at the time. They do now. So that's me.
Thanks, Amy. Shanti?
Hi everyone, I'm Shanti. I'm the research advisor on TAC's team. I've been at TAC for around 2.5 years and I'm based in New York.
Thank you, Shanti. And I think that is it from our team. All right. Um, okay, well, just a reminder, introduce yourself, your connection to AOT, and where you are tuning in from. First on my screen is Amy Cherry.
Hi, I'm Amy Cherry. I work in Shiawassee County in Michigan, and I monitor all of the treatment orders and deferral agreements in Shiawassee County.
And
Awesome.
Shiawassee, what's the big city there? Or city, not
Owa-
necessarily big.
Owasso.
Okay, not big.
Not big, no. It's
Okay.
a rural county.
Okay, great. Great, thanks.
Joy Pearson.
Hi, I'm actually a parent, and I was referred to this by a case manager, and I just am here to learn. I have a son who is dealing with this, so I want to know everything I can find out.
And where is your son living?
Well, we're in Minneapolis, St. Paul.
Oh, excellent. I'm in Rochester.
Okay. I'm very familiar. Mhm.
Welcome, Joy.
Thank you.
Janet, good to see you.
Hey everyone, yep, I'm Janet Hayes and I am in Louisiana. I started the AOT court program with Judge Kern Reese in Orleans Parish. I'm now living in St. Tammany Parish, but I still work in Orleans.
Thanks, Janet. Rochelle.
Hi, I'm Rochelle Rowell. I am in Muskegon County, Michigan, and I am the AOT coordinator for our CMH here, which is called Health West.
Awesome. Welcome, Rochelle. Malcolm, I saw you put your introduction in the chat, but feel free to also share with us verbally.
Oh, already. Thank you. Oakland County, Michigan. We're on the northwest corner of Wayne County, which is where Detroit is. And we're a pretty big county, about 2 million people, I think, here, or at least 1 million. I am not specifically an AOT monitor, but I work with the AOT monitors here. We've recently been able to expand our AOT program quite a bit with new personnel and new jobs for them. I'm primarily working with the probate court. I'm the person who writes the alternative treatment reports for our mental health hearings. So I'm typically in a position where I'm making recommendations for whether or not a person should have an AOT, and if so, what should be on it.
Amazing. Thank you for joining, and shout out to Michigan for really turning out.
Yeah, I actually know where Shiawassee County is.
There you go. Nick, good to see you.
Hi, I'm Nick Schrantz from the state south of Michigan and the current national champion Ohio State Buckeyes. I am from, thanks, Amy. I am from Butler County, Ohio, which is the county north of Cincinnati. So we're Southwest Ohio. We've had an AOT program for about 25 years, and I've been the AOT monitor for the last 18 years. And we have a caseload of about 105 people.
Thank you, Nick. I am so sorry, I might mispronounce your name. Nilifer?
That's great. Thank you. Yes, my name is Nilüfer Isvan. I'm a senior researcher at the Human Services Research Institute. We're based in Cambridge, Massachusetts, and we're currently conducting the evaluation of New York State's AOT system to prepare a legislative report. And I am here to listen and learn. We have a mixed methods approach. As a part of that, we have been interviewing judges, monitors, public defenders in the AOT system. So this is my opportunity to hear from the rest of the country. Thank you.
Welcome. All right. All right, I just switched screens. Erica, I'm going to have you hold off since you'll kick off our telehealth discussion. Lindsay.
Good afternoon. I'm Lindsay Gibson, and I am here from Dallas, Texas. I am the project director for the AOT program here.
Welcome, Lindsay. Right, and Dawn.
Hope my speaker works this time. Is it working?
Yes, we can hear you.
Okay, so I'm Dawn Marie, and I'm from San Luis Obispo County, California. And because of California's budget cuts, we have an AOT on our county website, but it's not really active. And it needs to be because now we've added care court to our county agenda, and we need our AOT to be able to go out and help get the care court that our county put together to become more active. I'm a family member, and I am on the board for our SLO County NAMI. And I know Janet. She's my buddy from afar.
Thank you, Dawn. Welcome.
I think that's so funny. We use it's not funny, but we use Slow's website as an example of how good it can be. And to hear that they're not using it is disappointing.
The website's beautiful.
It is awesome. Everybody should have a website and a program that matches.
Exactly. And that's why I'm here to learn because we've also taken on another program, Crisis Intervention, new boots on the ground. And the gal that's doing that used to do what she could with the AOT. And I keep inviting her to this forum. And hopefully one of these days she'll fall into place and join us for a little while.
Agreed.
All right. And David Gonzalez. David, if you're there, feel free to interrupt us and introduce yourself, or you could introduce yourself in the chat. Did I miss anybody? Okay. So, like I mentioned this, oh, perfect. Thank you, David. This group is really kind of what we make it, and it's to talk about, barriers you all might be facing in your work, kind of crowdsource some advice and tips based on what others have done in their communities. And sometimes we have topics and an agenda. And so I just want to start with a discussion of telehealth and AOT. And then kind of depending on how interested y'all are, we can definitely move on to addressing other issues as well. But one thing we hear a lot is that there is a shortage of psychiatrists, depending on the community. And we want to explore creative solutions to that. And so one of those is utilizing telehealth for seeing the psychiatrist. And Erica Lopez, who is on this call, is going to introduce herself and talk a little bit about how this works in Laredo. So go ahead, Erica. Thank you.
Hi, good afternoon. Like Ms. Brooke mentioned, my name is Erica Lopez, and I'm the project director here for Laredo's Public Health AOT program. We are located in Texas. We are in the border with Mexico. So we do provide a lot of services for individuals who are primarily Spanish speaking. Before I forget, this is Ms. Ana Moreno. She's our court liaison, which is pretty much a court monitor. In Laredo, not only do we have a shortage of psychiatrists, but also a shortage of psychiatric hospitals. We do not actually have a psych hospital. The closest to us is about 2.5 hours north and 3 hours south. Those are the closest psych hospitals to us. We have not had an in-person psych, not just in public health, but in the city of Laredo, including the LMHA, for a couple of years. Probably since before the pandemic. So with us, we have always offered telehealth services in our program, which is AOT, as well as our community mental health program and our HIV STD program. All services have been offered telepsych. Unfortunately, at first, I want to say probably 2019, 2018, a lot of people were uncomfortable, as we would hear, speaking into a TV screen. But now they did get very comfortable because unfortunately, that's the only service we do have to offer, not just with us, but in the entire city. They can go an hour south to Zapata, and it's also telepsych. So anywhere around, that's all the services they will be getting, unfortunately. But it has been working great with us. It can get a little bit pricey, but if you see it in the long run, it is cost effective simply because they aren't hired on as full-time employees, which would take up a huge chunk of the salary. In at least for us that we are grant funded. So what we do is we do contract with a company called Televero. And one of the primary requests I had was for this individual to be bilingual. I want to say 99% of our population is bilingual, some of them being primarily Spanish speaking. So that was a great priority for us, that they did have to be Spanish speaking as well, which we have been very lucky to do that. Our population is very special. Like I've always mentioned, we do have a lot of Mexican and Hispanic beliefs. So I think it was very important to find a psychiatrist as well that respected that. And that was something that we discussed right from the start. I didn't want to be complicated, but I did want our participants to feel comfortable with them. What we do for now, since AOT is a small caseload, we go ahead and have one day assigned only to AOT. On Tuesdays, they do have same psychiatric company has the day with our community mental health grant. Thursdays, they have it with the STD clinic. So our Laredo Public Health Department does take up 3 days of their schedule with this one psychiatrist. And it's been working great. They've been working very well in taking suggestions from us. And it's something that we noticed that we hadn't seen with other companies, that our psychiatrist actually meets with us virtually once a month. If we do have new clients coming in, it's actually twice a month. So we do meet at the beginning of the month virtually with all of our caseworkers and counselors to discuss pretty much any concerns that we do have with our participants. Then the day after court, we do go ahead and meet with them and discuss any new potential clients that are coming in, so that he does have an idea of what he'll be meeting the following week. So far we've had a very, very good experience. He goes ahead and asks a lot of questions before making any decisions to see what can be supported through the grant. And we have had zero complaints so far from any of the participants. What we do guarantee them, as opposed to other agencies, is that consistency, and it's something I did request from the company. One of the complaints that we do get from the LMHA is every time they go in, it's a different psychiatrist. So they're never able to establish rapport with them. And that just makes their experience a little bit draining. So with us, what we're able to do is we do guarantee that same psychiatrist with them every single visit. Initially, we do start off by seeing the participants sometimes once every 2 weeks, then one every month, and then it can go off to one every 3 months. If there's any changes in medication, then we go ahead and approve for them to be seen every 2 weeks or every week, depending on how drastic the medication changes, so that it can be adjusted. Luckily, they've been working great. We had somebody recently hospitalized in a psychiatric hospital in Mexico, not by us, but there was an accident that happened in Mexico. She had an episode there, and it was an adjustment for us because the medication provided in Mexico is very different than the one we provide in the US. And the psychiatrist and the company worked great with us. We did translate for them some of the medical records that were sent over. And although he did not necessarily agree with the medication being prescribed, we came up with a treatment plan for the participant, where this participant was slowly tapered off the medication, and then we slowly re-implemented the medication she took prior to being hospitalized. So far from experience, it's been great. One of the perks also of telepsych is, in the event that the individual does not have transportation to their appointments, we literally have the MOA go over to the home if they have a strong internet connection and with the laptop, and they're able to also provide the telepsychiatry services at home. So that's something that has been quite beneficial for us. Not with AOT, but with Public Health Department, we also have a mobile unit, which is kind of like a small RV, and it is equipped to do telepsychiatry as well, where the screen is already installed. We just go ahead and connect with the psychiatrist. It's private, it's soundproof, so they'll be able to meet as well with the psychiatrist. We don't treat the crisis, but yesterday we had maybe a pre-crisis, and our psychiatrist was more than willing. We let him know at 9, and he was scheduled by 10 a.m. and the participant was able to be seen. They made some med adjustments. So that's been working great. I think my recommendation is establish what you want and your budget right from the start. They are a business at the end of the day, and we do have to be cautious of that, because At the beginning, they did want to schedule weekly visits due to diabetes or weekly visits due to hypertension. So we had to go ahead and catch that early on and kind of put a stop to that. And remind them we are going to set them up with their primary care physician, but we're here to treat their psych component of treatment. So I think once you establish those boundaries and you're very careful in them respecting our boundaries and us respecting theirs, then I think that relationship kicks off pretty well. But so far, we've been doing this is our third year doing telepsychiatry with AOT, and we've had zero issues. The participants have actually left the room saying that they feel great, that they feel that this psychiatrist actually understands them and is willing to listen to them. So far, it's been quite successful. And I think what differs us from the other agencies is that consistency. So I think, especially for AOT, I think that's something very important to establish from the start to see if they can assign one primary psychiatrist and one backup in the event that they're out to maintain that consistency with our participants.
And Erica, you said that they do speak Spanish. I mean,
yes,
that's
yes,
amazing.
they do. So our doctor, he's not Hispanic. His last name's Dr. Linford. But he does make sure to speak Spanish, at least the basic Spanish of it. So he is able to communicate with our participants. And if he has any questions on any beliefs, on any traditions or anything like that, he makes sure to consult with us to make sure that the participant isn't delusional, isn't manic, or anything on the sort. So he does try his best to understand our culture as well to make more educated decisions on their treatment.
That's amazing. I'm kind of curious, Erica. I know you said that you haven't had any complaints or anything like that, but you did mention it could be costly. Part of the reason we're interested in this is because some communities may not be able to implement for the reason that you guys mentioned of just not having any psychiatrists, and this could be a solution. But in terms of cost, I guess, or besides cost, are there other downsides that you've noticed?
Sometimes I think aside from the cost, it would just be that they have a difficult time sometimes seeing in person, quote unquote, manic behaviors. And we'll notice it in person and we'll tell them, hey, like this person is acting a little manic. And we'll explain to him and he'll say, oh, well, I didn't really notice it in our session. Because again, they're just being seen here. Body language is not a huge component. But the good thing is that they do go ahead and maintain that communication with us. So if we do tell them, hey, this participant is being a little manic and we mention the symptoms, they'll go ahead and schedule them the next week and pay attention to those symptoms. So I think just like with anything, it's just that body language that has been sometimes an issue. But then there's times that we miss stuff and he's able to catch it because there's nothing distracting around the person. It's just them two. So there's nothing else to distract them from the session. So he's picked up on things that we sometimes miss in person as well.
You mentioned because the body language, one of the important aspects of a med visit is side effects. And some of those side effects are visual, not that they can't see, but, just mannerisms and things that manifest because of the antipsychotics. So are the physician, is the psychiatrist able to pick up on that? Or are you all trained in that?
We do have a certified medical assistant that pretty much her primary responsibility is to focus on the telepsychiatry. So she does have years of experience in medical facilities as well as mental health facilities and with the IDD population. So she is able to pick up on either flat affects or twitches or different things that can be components of the side effects.
Hello?
What we noticed with other programs is that they do not, at least within the health department, they do not have one individual assigned to telepsych. And that's when it becomes an issue because any random person will take vitals, input them, but they don't know their behaviors or keep up with, oh, it's normal for this person to have a tick because they had it before the antipsychotic. Or this person has always had a flat affect, as opposed to us that this medical assistant is assigned directly to our participants. Then they're able to pick up on any differences, on any changes. And that's something that we've recommended to the other two programs because it is a team effort and we pretty much try to pick up where unfortunately they can't see. But there has been times that the psychiatrist has picked up on stuff where this person used to be extremely energized and we notice that now her answers are very yes or no, or she's unable to stay still. They're unable to focus. So we pretty much take vitals, take a urine analysis if they do have a history of substance use prior to them seeing the psychiatrist. If they do have a history of diabetes, we also take an A1C level or a glucose level to let them know. Because sometimes it can be medical, especially if they do have a history of it. And we'll go ahead and advise the psychiatrist whether their sugar levels were a little high today, whether they had a headache and their blood pressure was low or their blood pressure was high. So those are things that information we provide to him so he can be aware, but then he'll also text us and let us know, hey, this person's dozing off. I don't know if the medication's strong or maybe they're under the influence. Can you go ahead and do a UA? So it's always important to maintain that communication, and it's kind of a team effort where if our MOA doesn't pick it up, hopefully he will, or vice versa.
That makes sense. Thank you, Erica. I'm curious if others on the call, if you use telepsychiatry in your program, if you encounter the issue of there not being enough psychiatrists, or maybe the psychiatrist you have doesn't have the availability that you would like. Others?
Hey, Brooke, Janet in New Orleans. So I do mostly coordination for the AOT court in New Orleans. I'm not a monitor. We do have a monitor. I have a question about that for later. But so we partner with, we're lucky to have 4 ACT companies that operate in the New Orleans area, and they all see their patients in person. The challenge is the psychiatrist is typically only able to go out once a month, which is that is the standard. And one of our ACT teams, the psychiatrist will see AOT clients twice a month, which we really appreciate. And she's very assertive. She'll go out anytime. But it's all in person. I will say though, for commitment hearings, court hearings, that sort of thing, but for commitment hearings, including whether or not a person meets criteria for long-term admission to a psych hospital, the psychiatrists that do those evaluations do those by Zoom, and they're very good at it. They pick up all kinds of stuff. They're super expert, and our AOT evaluations that we get done for the court hearings are done mostly by Zoom. And again, the psychiatrists, I don't know how they do it, but they are fantastic. Some of the very best evaluations I've ever seen have been done by Zoom. So I will say that. So do your treating psychiatrists not provide the evaluations or the testimony for court? Or
That's right.
Okay.
So because don't forget, almost all of our participants are coming into the AOT court program through the community referral process. So we are almost always having them evaluated by a third-party psychiatrist and then referring to an ACT team. Now and we do actually do that for extension of judgment also. A lot of our ACT providers, whether they're a nurse practitioner or a psychiatrist, feel uncomfortable with doing the evaluation because there's a conflict there for them. and they want to keep rapport with their patients. So we will farm out the evaluation to an expert forensic psychiatrist that's what they're doing all day long in the criminal justice system and for civil commitments as well.
Thank you, Janet.
I wish they were coming in from the hospital referral side, but we, for whatever reason, just the way things materialized and where we are, it worked out that way and it's working out well. But for the hospital referral process, the psychiatrist would definitely be the hospital. It would be the treating psychiatrist as well.
Got it. I see a couple comments in the chat from Malcolm and Rochelle. Court hearings on Zoom. Okay. Malcolm, I'm curious, do any of y'all's participants meet with the judge for check-ins outside of that initial hearing?
That so far has not been happening. We are making some inroads with one of our probate judges to possibly start that in the foreseeable future, but that's in its infancy right now, if not an embryo.
There aren't too many counties, and you guys from Michigan, correct me if I'm wrong, that are doing the status conferences. I believe that Genesee County is the only, well, I'm not going to say the only because, like I said, I don't know, but I know for certain that Genesee County here in Michigan, they do status conferences on a regular basis.
Got it. Yeah, and I
think.
Oh, sorry. Go ahead, Amy.
I don't think they started that way. That was something they added later on. But yeah, I think that's true. That it's rare in Michigan. That doesn't make AOT any less effective, by the way. Just so you know.
Well, I'm interested to see about that.
You know what? We all are. We'd all love to see some data saying one way or the other. And what I will say is that I think a good, compassionate judge can be a real value add. But again, all the good data we have comes from programs that do not have an active judge. So,
and I'm going to piggyback on Amy's statement that I think one of the realities of AOT is we have 50 states and most states have 50 to 80 counties, and so all these programs are different. But I think that AOT works when there's contact, not necessarily with the court, but about the court process and the order and the focus on treatment. And, in Ohio, we have many different models of how that works. Some do have active status hearings, like Summit County has regular check-ins with the judge. And that's one process. That's one program. It works well. Other counties are more what I call case manager driven. People are under civil commitment, are getting treatment from a specific ACT team or a specific agency, and that person or someone on that team is able to talk with those folks repeatedly about treatment and how that interacts and be a liaison to the court. And then in my county, I'm an AOT monitor who does home visits and kind of brings the court to people's houses. And I go to hospitals, I go to group homes, et cetera, and kind of talk about the court process and treatment process with people at home. So all these models work, in my opinion. It just kind of depends on, like Amy said, do you have a willing judge or not? Or do you have a really good case manager who can guide that whole process? But having some sort of focus on court-ordered treatment is necessary. It's just how it's delivered can be county by county choice.
If I can say for us, we've been very fortunate where we do have our monthly follow-ups in court with the judge. So sometimes we are there for long periods of time since we do new clients as well as existing participants as well. But I think it's been very beneficial to our participants. They get so excited when the judge notices that they grew a beard. And it's something that we hadn't noticed before because we just see them so often. But when the judge does, it literally makes their day. And they'll come back and they'll be talking the entire time how the judge noticed that their beard grew. Or if they'll wear a graphic tee one day of a band, the judge will tell them like, "Oh, like I like this band." And the next month they'll keep that in mind and try to have a conversation with him and will wear a different graphic tee with a different brand to try to go ahead and establish that relationship. And so far, it's been working great for us, where Judge does keep that consistency in seeing them month by month. And kind of with clients that have been with us for over a year, we do every time they walk in, we play like a mental montage of them, like their first AOT hearing to how they've improved so much during the year. But so far, I didn't realize how lucky we were that our judge is willing to see them every month. Even he says like even if we have to stay later that day, we stay later that day to finish everybody that attends. But he gives everybody an independent hearing. So everybody waits outside, calls them in one by one, and at this point does have that one-on-one, I want to say, relationship with them. So the judge does feel a part of AOT as well as our attorney. He's at every court session as well.
Thanks, Erica. I think, to Amy's point about us, and I'm also thinking of this because I read kind of an internal brief that Shanti put together about the Black robe effect and how there's a lack of research. It's really just anecdotal, and we have these research gaps that we need to fill regarding its impact on outcomes and participants and stuff. And so I think that it's important to also remember that we've only seen this a handful of times, but if for whatever reason, your judge just doesn't understand mental illness or is not interacting with participants in a way that is helping them, maybe is focusing on kind of punitive measures or threats or so, you can tell if the participant is not benefiting from the check-in. And so you wouldn't want to have that participant continue to see the judge if it seems like it's negatively impacting their recovery. All right. Any other thoughts about telehealth and the value or lack of value? Awesome. Well, I want to open it up to see if anyone has a particular issue they want the group's support on, something going on in your community that you could use some feedback on.
So, Brooke, I was thinking when we got on the meeting, I do have a question for AOT monitors in general. People, Nick, I'm looking at you and some of the other folks that are actually doing the monitoring. So how much are you interacting between the participant and the provider in between hearings? So, I mean, our hearings are typically once every 2 weeks. In terms of best practices, what would you think would be an adequate amount of time that you would be spent? I know it varies depending on the acuity level of the participant, but how much time on average are you spending between hearings doing troubleshooting, checking in, communicating with the provider? Are you reaching out to clients, or are you only responding when they're reaching out to you? Are you being more proactive, more assertive? Like just curious in terms of monitoring. actual monitoring and the time needed for that, if people could comment.
With our AOT monitor, she is a part of the AOT team. So we do interact daily pretty much. But what she does 2 days prior to court, she'll sit with each caseworker and sit with the counselor and pretty much has her list and goes down the list on every existing participant. And then she's the one that reports to the judge. So a thorough sit down would be monthly, but she only meets with the caseworkers and pretty much with the staff, not with the participants.
Thanks, Erica.
So I'm lucky that my full-time job is to be the AOT monitor, and it's I have a protocol that I follow, which is I see everybody after they come out of a hospital. I see them at home within a week or two of discharge. I'll see anybody if they have had some event, an arrest, an eviction, a psychiatric hospitalization, a notice from the treatment provider that they've stopped treatment or are questioning treatment. And then I see everybody in the several weeks prior to what we call a review hearing. And we have a review hearing at 90 days after the initial commitment hearing, generally at the hospital. Then 90 days later, for all these, we get a prescriber, the treating prescriber, to write the actual evaluation that serves as the expert testimony for the hearing. But then I see people prior to court, and then after every 90-day hearing, it's every subsequent 180 days until the doctor recommends dismissal. So in addition, I mean, I have 105 people. State statute in Ohio demands a monthly report from the case manager. So I collect 105 reports. I review all of them. I have contact with the agency, the group home, etc. if I notice that there's something wrong or problematic in treatment. If there's not, and treatment's going well, then I file it, and then those reports and the doctor's report, and then a report that I submit to the court is what is used as the expert testimony at the hearing. I kind of give more of a nuts and bolts and a summary report. So I get more involved when things aren't going well, and I'm less involved when things are going well. But yes, I'm proactive when there's a problem. And if there's not, then I don't need to be as involved.
Thanks, Nick. That's helpful.
Any others want to share their model with us? Love to hear.
May I ask just a couple of parent questions?
Sure.
So I'm new to this. So who sets this up? The AOT monitoring.
So in Minnesota, the counties typically have treatment teams that do this. There's not the robust monitoring that we recommend, which is why.
All I know about, I mean, my son is in an IRTS facility right now.
Right.
He has some monitoring there, but the way I understand, they're very lax about, everything, it seems. But they do see to it that he takes his medication while he's there. Well, then when he gets out in a couple months, I'm wondering how it's going to be monitored then. He's been medication non-compliant a lot. So he's on that close the reel and he's doing really well. So I'm just really trying to figure out how this is going to go when he gets out. So,
is he on an outpatient treatment order? I mean, he's in a treatment facility now.
Yeah. So,
but will he be court ordered?
Yes,
to
he
treatment?
is court ordered. he was hospitalized in Anoka for 6 months,
Okay.
and they put him on that Clozaril, and he is doing well. But and then they're taking care of making sure he takes it, and he's not objecting right now to it. But I'm just looking ahead to the time when it's going to be my responsibility to see that he takes it, and I'd like to know if there are support systems that will bring it to him, watch him take it, all that kind of stuff. He has had that in the past, but it was real lax. Half the time the people wouldn't show up, or a different person would come and they would knock on the door. If he didn't answer immediately, they would just leave. Different things like that. So I'm just wondering how it all gets set up, and if there's monitoring, that's awesome.
So it sounds like there's some confusion about, and I'm confused a little bit about the court order that he's under. Is that for an inpatient hospitalization right now?
No.
The court order is for outpatient. Okay.
He was inpatient for 6 months. Now he's in an IRTS, which is intensive residential treatment, and he's there for a couple of months just to reinforce taking the medication. And so when he gets out of there is what I'm wondering. So, I'll try to, his case manager says he doesn't have any way of providing service to see to it that he takes it. So I'm just wondering, where does the parent fit in here? How does the parent?
So Joy, can I ask you, so he has been court ordered to commit to outpatient treatment under a judge in outpatient in the community, like a civil judge?
Well, I'm sure it carries over, doesn't it? I mean, he was ordered to take it when he was in the hospital. I think that's carries over into.
Oh,
and he's under commitment. He's under commitment. So I'm sure as long as he's under commitment, I mean, it's court ordered and under threat of, if you don't take this, you have to go back to the hospital.
Who filed okay. So just so I understand, while he was hospitalized, there was another order that when he gets out of the hospital, he must continue to take his medications when he's in the community.
I think it's all one thing. I don't think there's a difference between when he's in there and when he gets out. I think it's mandatory as long as he's under commitment.
It sounds,
Amy, back to you, Amy, and then also the difference between case management and monitoring too. I think it was there's some confusion.
Yeah, so when we talk about AOT monitors, they typically they have two roles. One is to assure that the participant, the person under the court order, is treatment adherent. They monitor treatment adherence, but they also monitor the treatment provider. So the court order, and this is not true in Minnesota. Minnesota does not think this way, but we believe that the court order acts not only on the participant, but also the treatment provider. So, and Nick, you want to say more about that and what kind of experience you've had holding providers accountable?
I couldn't agree more. An AOT monitor is a treatment advocate, and treatment goes in both directions. We advocate for the respondent, the person, to participate in treatment as provided by their provider. But just as importantly, we make sure that the providers are listening to the respondent and are following up. I get monthly reports, and a lot of the reports that I have questions about aren't related to the respondent's adherence, but due to the provider's lack of aggressive or assertive case management. Why hasn't he been seen more than once in the month? Why has he missed 3 appointments and no one's done anything? Or, he told me 2 months ago when I saw him before court that he needed food stamps and you haven't applied for food stamps, or just a variety of things. So Amy hits the nail on the head about court orders And again, it can be an AOT monitor, it can be a judge, it can be a doctor and a case manager. It's all about advocating for treatment and eliminating gaps in the system and just getting through those gaps. And sometimes it's medication adherence and trying to create insight on your son's part or other people's parts to participate. But we also have case managers that come and go every month. And so there's gaps in that system, or our Medicaid and SSI and food stamp systems don't work real well, or there's a lack of access to good housing. And so the court order just really tries to bring everything together to make it work for people.
And
My
I'd be
son, go ahead.
I'd be curious to hear from Michiganders what your experience with AOT monitoring is.
Well, for myself in Muskegon County, I am just getting started. I had a whole nother issue. I couldn't even get to a deferral conference. So there wasn't anything. I don't even know these people and who they are. Like if they've never come to our organization to seek help and they're not open to us, I don't have this information. And if I can't get to them at this deferral conference, if I'm not being allowed to come, like how am I going to get the stuff that I need? If I'm supposed to be responsible for every AOT and deferral in Muskegon County. So after months and months and months, I reached out to our cohort and kind of got some suggestions. We ended up having a meeting, and I finally just last week started being able to go over to our hospital and actually meet these people and get information. So like, yeah. And then as far as monitoring goes, again, if I don't have their information, I don't know where they are. I don't know. But for those individuals who are open to Health West, they're on a treatment team. And so, of course, they're being monitored by their case managers. And I am just basically assisting the case managers as far as letting them know, hey, at the 45-day mark, your initial AOT is about to expire. You need to submit these particular documents to court by this particular date, and helping fill out petitions. That is what I am currently doing right now.
I was hoping that one or two of our AOT monitors could be here today. I personally invited one. I'm not aware that any of them are doing as much in the community like Nick talks about, and I tip my hat to you, Nick. I think we are more of we make phone calls. If we don't get you on the phone, we'll write letters. I know they attend deferment meetings as much as they are able to. Like Rochelle says, we don't always get notified, or if we do get notified, it's in 5 minutes, and we can't always make that. We do our best to work as a team. We also have AOT case managers who work with people who may not be eligible for traditional community mental health services. So then there's an extra layer of somebody monitoring that treatment and making sure that it is going in accordance with the court order. One challenge we have here in Oakland County is our judges will sometimes order things that are recommended by the testifying psychologist at the hospital, but the person may not be eligible under Medicaid for that service, like a ACT program or supervised living. And so that's something we're trying to communicate with the court.
So this group that we're meeting with here right now is not the AOT monitors, correct?
No, it is.
It is. Okay.
I'm not one personally.
Oh, I see. Okay.
There are a number of people on this call that do not have that role, but we don't. We take all comers. Anybody who's interested, you're welcome. Because again, we see it as a learning opportunity, and even if they're not doing that role, perhaps they have some insight into it or can share the way their program works, and that could be of benefit to all. So, um, one of the things that we preach is, and we recommend that you actually start with is community collaboration so that everybody that touches AOT is at the table. So if there are multiple providers in a county, they're all represented. The court is represented. The attorneys are there, and that you build the program in in collaboration. And so, for example, Mac, if you had started this way, your judge would understand that it's not their role to make level of care decisions and that they can't. I mean, they should be making well, it's also your the psychologist who's making these recommendations should be a part so that they can educate each other so you don't have these court orders saying you must do this and you're saying, well, we can't. So that's our ideal situation is that decisions, not necessarily clinical decisions are made by the treatment team, but decisions about AOT programs are made in this collaborative manner with the people who are actually involved. So law enforcement are part of this group. Crisis response is part of this group.
So this isn't really something that a parent will necessarily even know about. We're not going to be interacting with you. I just liked where they said that the judge would meet with the actual participant and, commend them for doing good or something that month. So how does that kind of thing fit in here? And do
that doesn't happen in Minnesota?
Okay.
We'd love for it to.
Yeah.
And
go
Joy,
ahead. Sorry.
oh no worries. I'll follow up with you because I have your email from the registration outside of this call to connect you with our family helpline and also just share a little more about maybe some things you could do to advocate in your community to improve kind of the care that would be available for your son. We also have a champions web chat, which is like this web chat, but it's specifically for people working at the grassroots level to advocate for AOT or improve existing programs. And there's lots of family members and caregivers in that as well, which I will invite you to because I think it might be more helpful. I feel like there's so much variety on how AOT is implemented across the country that there's also that variety within the monitor role, as you can kind of hear from this call. So it's not, I'm sorry, we don't have super specific answers. But we are, oh, sorry.
I'm just looking for anything I can find.
Totally.
I'm wondering, Brooke, if there are any other advocates in Joy's area. It's Michigan, I think, right? Or Minnesota. You're Minnesota, right? Yeah, it's that people who do who are advocating for better serious mental illness policy in general.
Well, we have NAMI. Yeah, we have NAMI.
I'm just wondering if Treatment Advocacy Center might know someone that they can connect you with in Minnesota.
So Mindy Grayling is doing her best. Our problem is that NAMI is not a fan. NAMI does not believe in this. So we have tried, we've made overtures to NAMI to try and educate, but the executive director is anti-AOT.
Wow.
Got it. So our NAMI chapter as well here, I wouldn't say they're anti-AOT, but they're definitely not promoting AOT. And so our situation is we do what we do and they don't get in our way and we don't get in their way. And at times, we connect. But we did what Brooke and Amy are suggesting, which is we started a community collaborative planning group for AOT and invited in all of the stakeholders who we knew would support AOT, that being law enforcement, the judges, DAs, people that encounter folks with severe mental illness on a daily basis who are handcuffed to be able to help them due to state policy or maybe federal policy. And so that's what we did. And that led to what's now starting to, snowball. We don't have snow in Louisiana, but you know what I mean.
Yeah.
Sandball into more and more interest and more. We have parishes beginning programs. So we invited NAMI as well. They just weren't interested in coming. So, but we did have disability rights groups. We had our mental health advocacy service attorneys. We had people in our circles who we invited. We invited in everybody to listen to what AOT actually is, and that what we're doing is actually it's actually accomplishing what they want as well, which is to keep people in the community. So yeah, I fully support what Brooke and Amy and others at TAC, and they'll help you, form a planning group. But I would just see if you can find a judge that understands the problem the same way you understand the problem with your son, who will partner with you. And not necessarily to start a court program, but to start a planning group. Mm-hmm. Because judges hold a lot of sway. And if they call a meeting, you'll find you probably will get better attendance if a judge or maybe a DA or a sheriff or maybe a representative or a senator is calling a meeting rather than just yourself. So that would be my advice, and start there, one step at a time. We started with nothing, literally with nothing for free.
Well, it was a new thing. At least I found something else to try. Thank you.
Thank you, Janet. And I want to be cognizant of the time. We are at the hour. But so if anyone needs to sign off, please go ahead. But if anyone has particular issues that they were wanting to discuss that we haven't had a chance to speak now, we would love to help.
So, Brooke, I'd just like to revisit my questions, since we're after hour now. And, for those who are able to go can go, or want to go can go. So our problem with AOT monitoring is we have someone who's typically reliant on whatever they get in terms of provider reports before court hearings, usually a couple of days before court hearings, and just repeating that to the judge. So the level of assertiveness and proactivity seems to be really lacking. I'm not sure if it's a time issue or, but that's why I'm looking for a guide, somewhere to start, maybe somewhere in the middle, to, be able to describe better how that rule works. Because I haven't, and there's also some tension between that person and me. So I'm not the best person to be able to rectify the situation, but I think the judge probably can. And I'm just wondering, I'm trying to find something I can give to him.
Tara, do you have a suggestion?
So, I'm from Ohio, and my actual job, I work for the Mental Health and Recovery Board in the county that I'm in, and I am the AOT monitor for the county. It's a very small program. We're still in the process of getting started. We just now have 4 people in the program, which I'm really excited about because it's been one for like a year. Um, but the way that our program is run is that initially they're all meeting with the judge every single week. And every single week, the treating agency has to submit to myself and to the court a status update report that basically says like what they've done over that week, both the provider and the client, where they're at, what they're working on, what's been continuing to be a problem for them. And so I am a licensed therapist. I have experience working on ACT teams and things like that. So I actually ask a lot of questions. When I get the reports, I'll say, like, hey, did you try this? Or have you thought of this? Or what are you going to do to address this? So I think that me not being the treatment provider, but being the AOT monitor is like a good separation, I guess, because I don't have to just rely on what the provider says, right? Like because I know the clients, I go to court every week, I meet the clients, I see what they do, I see what they say. And so I think that if I have questions, I ask them, and then that's a really good way for the judge to then get the information that she needs. Our judge is also really good at asking questions and saying, no, I'm not okay with that, or I don't think you're doing the right thing. So she's had a lot of pushback sometimes on the treatment agencies as well, but I feel like having that separation in that position has been really helpful for our county.
Yeah, thanks, Tara. That's good information. And we kind of work in a similar way, only maybe not as hands-on as you are, which I would love to see more of that. But also, so we have 89 judgments, and so our court hearings are usually, I mean, we may be seeing anywhere from 40 to 50 people in one day. And we started also with 2 people. We had 2 people for a year, maybe, and then we had to change the whole law. So we didn't start to really, the floodgates didn't open for us until we made some major law changes to allow interested parties to petition rather than just hospitals. But anyway, I'm digressing there. So, but so there is a meeting 2 days before court hearings, and we'll go over clients together with this person, myself, and the judge. But then on the day of the hearing, we'll find like whoever shows up is what we get. So like if folks don't come to court, I would think that a natural response to that would be to follow up and find out why, right? Either with the provider or with the respondent themselves, or if the family member's the petitioner, with the petitioner. And just don't see that level of interaction going on for whatever reason. So again, I'm kind of looking for just a guide. If there's anything written, I mean, Treatment Advocacy Center folks, if there's anything written down, just like short, that's kind of a step-by-step, or, some sort of a directive for AOT court monitors, something like that might be really helpful to us at this stage of the game. We're getting the job done, but not everyone's sharing their part of the load. That's the biggest problem. So some of us are doing more than we're supposed to be doing and can't do our own jobs, which is holding us back from moving the program forward. So anyway, but it's interesting to hear other people's experiences with monitoring. And I mean, y'all are doing such great work. So appreciate everything you're recommending.
I really recommend having Judge Reese lean on the treatment teams and set the expectation. You know how we say the black robe effect, respect authority. Well, treatment providers need to do that too. So, make sure he sets the expectation that this is what I want to see. This isn't because the monitor is requesting this. It's because this is necessary. So I know he's such a nice guy. It's hard for him to play the
he's
heavy.
very good. He's very good. He appears like super nice, but he definitely has a black robe side of him, and we've seen that. And he will lean in on the treatment providers if there is an issue. He just does it very politely, but their providers, they respond really well to him, we have great partnerships. We have no contracts or MOUs with any of these providers that we work with.
Right.
All done out of collaborative spirit. You know, we all want the same goals for our people. So I think the problem that I'm having is getting the person who's in the role of the monitor understanding their job. So anyway, we'll see where that goes. But the
Hey,
judge is
Janet.
excellent. Judge is excellent.
I'm sorry, everybody. I went off camera because my dog was barking and would not stop.
I want to see
So
the
I had
dog.
to let her out.
We want to see the dog. Come on.
Yeah, be careful what you wish for, Janet. She's kind of ugly dog cute. But I just wanted to say I will send you our roles and responsibilities of AOT team members document, and that has more on kind of the specific duties that we recommend the monitor undertaking. And then I also wanted to share with the group, we have two fairly new resources that we developed that might be helpful to you. I'm going to put them in the chat. One of them is on when to end the AOT order or when to graduate the participant. And then the other is on the treatment of co-occurring substance use in AOT. And I am going to put those in there now. And I'll go ahead and when I send out the follow-up with the meeting recording, I can share that roles and responsibilities of team members document with everybody in case it's helpful for others too.
Thanks, Brooke. It's a good refresher anyway, just for everyone, I think. And thanks. And the when to end the order is really good also. It's so hard we should have a meeting about that because 80% of our graduates have relapsed and had to come back into AOT, and the second time around has been 10 times harder than the first time around. And it's really a poor record. But when they leave, when we graduate them, everybody's agreeing that they're ready to move on, and for whatever reason, they all go off their medications and have to come back in. But maybe they're all just like super clever about fooling us. But we keep them in. Amy's going, no. We keep, 2 years on average is when we're graduating people, and they're perfect. We have one guy, well, he hasn't graduated yet. He's in his third year though, but he just graduated from university. He went back to finish, and he's on the dean's list. He got the highest score out of all his classmates, and he has done amazingly well. And every single court hearing, every single interaction with the provider, he says, I am only taking my medication because the judge tells me to. If I weren't under this order, I would not take my medication. So we're not letting him out, but he's honest.
Yeah, not everybody is that insightful or that honest.
Yeah,
but
he's just honest. He has no insight. He's honest.
I think, well, he has to have some if he knows that. But I think this would be a good thing to bring up next time we meet. So
I would love that because that's one of our biggest challenges.
I think that's a great topic. And yeah.
And now we have a new document that Brooke is going to share with us all that we can study beforehand. So we'll all come prepared.
There you go. There you go.
In between in our free time.
Yes. Because we all have so much.
So much.
Well, everyone, first of all, I want to thank Michigan for showing up en masse. Way to go, Michigan. And
Thank you so much, Erica.
Yes.
For sharing about how that telepsychiatry is working. That's super helpful.
Of course, and if y'all have any questions, just let me know and I'll try to help you as much as possible. I was pulling up some invoices. Initials, they usually charge us $350 for the initial eval and about $220 for follow-ups. So that's pretty much the rate that we're paying.
Thanks, Erica.
That's good. We pay $750 per evaluation, unless it's already a treating provider and then it's free. But for a third-party evaluation, we pay $750. But I have
expensive.
some unrelated, is related, but not monitor related news. So our MCOs are fabulous. I love our MCOs because a lot of the psychiatrists that I'm contracted with to do AOT evaluations are now case reviewing. And they're directors of the MCOs for psychiatry. So we've infiltrated all the MCOs through our relationships with psychiatrists. So AmeriHealth, we just got a word back from the psychiatrist I work with there who checked with legal, and apparently they got permission, or it's not permission, but they got the confirmation that the MCO can pay for legal services for an AOT commitment or an interdiction, which in Louisiana would be a conservatorship. So that was kind of exciting. We didn't expect that. So you never know where those resources are until you ask, right?
That's a fact. That's a great note to end on. Wow.
Well, thank you so much, everybody.
We'll never end. We'll never end. We have to go.
I just wanted to say really quickly before you guys go, I experienced the Black Robe effect at the conference that you all put on, which was a great conference. And the reason why I say that is because we all had our name tags on, but it didn't say what you did. And so I'm sitting there at the table, unbeknownst, with judges, and I didn't know. And then when I found out and discovered it, I was like, oh, I hope I didn't say anything stupid. Oh, maybe I shouldn't have did that, or maybe I shouldn't have said this. And then so now I'm on my best behavior going through this conference because I don't know who I'm sitting around. So it worked for me.
It works for most of us, I think.
Yeah.
We all sit up a little straighter when yes, Your Honor.
It's true.
Yep. It is true. And I react differently with our judge when he's wearing his robe and when he's not wearing his robe.
All right. Well, y'all can, for those of you still on with us, you can expect an email with me with the recording and that resource early next week. And thank you so much again for joining and for taking the discussion over time as well.
Yes. Take care.
Thanks, everyone. Nice to meet everyone.